Sajay, you are audible and your slides are well visible.
Okay, so at the outset, my sincere thanks to Professor Mamoon, his team, and the Forum for the Study of Liver Bangladesh for giving me this opportunity to interact with you this morning on the International NASH Day. And we wish all the best to our patients with fatty liver disease today. So my job is today is to take you through the pharmacotherapy of NASH, which is beyond the vitamin E and pioglitazone. So before I go into that, I think I'm pretty sure these are all hepatologists as the audience and they all understand this. But just to add, I also understand there are some residents who are participating in this webinar. So we all know about the spectrum of fatty liver disease, the non-alcoholic fatty liver disease. So the importance here is that some patients can just have fat in the liver, whom we call it as NAFL or simple steatosis. And 15 to 20% of these patients do progress onto a disease called NASH, which is with inflammation and with or without fibrosis, which has the propensity to progress onto cirrhosis and its complications, including extrahepatic complications. So it's very important to differentiate between the two. Fatty liver disease is kind of, I would say, a major issue all over the globe, including Asia. And this particular, meta-analysis showed that the prevalence of fatty liver disease in Asia could be around 30%, which is almost same or little, I would say, more than the global figures what we have. If you look at the different parts of, Asia, and I put up Indian figures here, in the urban part of India, I think our figures are from maybe 16 to 50%, as high as 50% of patients in general population actually have fatty liver disease. I have picked up few studies from Bangladesh also, and this is a general population Bangladesh study which showed 33% prevalence of fatty liver in the general population, which is also quite a bit. But as I said in the beginning, it is very important to differentiate whether it is NAFL or NASH, because the pharmacotherapy, what we are talking today, would be directed towards the patient, those who have NASH, with or without fibrosis, rather than towards the patients with NAFL, who can best be managed with lifestyle interventions. So this is again our own recent data, which we presented as a plenary paper in the APDW in 2019. And we have a consortium in India called the Indian Consortium on Non-Alcoholic Fatty Liver Disease, ICON-D. And this was the data of around more than 2,000 patients, which is a interim analysis we did. And what we found was that based on the ALT, and if you take this as a surrogate marker, which is not a good marker for NASH, 45% had raised ALT. But more than important than that is that on FibroScan, which was available in around 1,300 patients, 41% of the patients had significant fibrosis, which was defined as LSM value or a liver stiffness measurement of 8 or more kilopascals. And 12% of them actually had cirrhosis, which was defined as an LSM of more than 13. We also have a data on liver biopsy from our country. This is a data of 1,000 liver biopsies from the Institute of Liver and Biliary Sciences. And if you look at the figures here, NASH is 61% NASH. And if you look at the fibrosis, around 60% of the people actually have what we call significant fibrosis, which is F2 and more. So I think the quantum is quite a bit in our country. And I picked up this again, a study from Bangladesh, which also said that the definite NASH is around 40% and around 30% actually have significant fibrosis, which is F2 or more. So I think having said that, I think what we need to understand is that we all facing this, kind of a pandemic, I would say, global issue of fatty liver disease, and significant number of them actually have what we call significant disease in the form of NASH, which is with or without fibrosis. So in addition to the lifestyle interventions, which have to continue, whether you have NAFL or you have NASH, the exercise, weight reduction, and the control of, risk factors like diabetes, hypertension, and dyslipidemia, they have to continue in everybody. But yes, pharmacotherapy, which is usually, advised by most of these societies, but though not approved by the regulatory authorities, as the pioglitazone and vitamin E. So now the issue is that why do we want to go beyond vitamin E and pioglitazone, and why are we talking about beyond vitamin E and pioglitazone today? The reasons are that there is a data to suggest, and I'm not going into that data, that both vitamin E and pioglitazone do improve NASH, which means necroinflammation does improve with these two drugs, but both of these drugs, they fail to improve the fibrosis. So that is, and we know in fatty liver disease, and in particular, and in Journal for All Chronic Liver Disease, fibrosis is the major determinant of any chronic liver disease. So they do not improve fibrosis. And the PIVEN study, which did the study on vitamin E and pioglitazone, also showed us that there is a rebound of ALT which happens when you stop these two drugs. Unfortunately, these drugs, the data what we had was not in cirrhotics, so these drugs are not recommended in high fibrosis or cirrhosis. And then the issue is about the side effects. We know that vitamin E has some association with carcinoma of prostate, and then there was some data to suggest that it can actually increase an all-cause mortality, which was refuted later. But similarly, with pioglitazone, you have the issue of pedal edema, weight gain, cardiac issues, and also the risk of maybe carcinoma urinary bladder. So that is the reason, and the people were, working, and to tell you, there could be at least maybe 200, clinical trials which are going on across the globe, and which are actually looking at the efficacy and safety of various drugs in patients with fatty liver disease. Now, to start beyond vitamin E and pioglitazone, what I have done is I divided this into various headings. And the first is that I'll talk about a drug which is approved in India. So it is not approved in other countries yet, but this is approved in India by a regulatory authority, the DCGI, or the Drug Controller General of India. So the drug is saroglitazar, which is basically a PPAR alpha and a gamma dual PPAR agonist. And I'll talk about this a little later. Then I will also give you a little overview about some of the drugs which are available for other indications. For example, anti-diabetic drugs, probiotics, vitamin D, and they have been tried in patients with NASH, but have not been approved for NASH either by the societies or by the regulatory authorities. I will also then talk about a drug which is now is the hot topic, which is the obeticholic acid. Again, approved for other indication like PBC, has been tried in NASH, and we have some very good encouraging data. I'll show you that, but still not approved for NASH. That is two. And finally, I think we will talk about some of the drugs just to complete the list. And as I said, there are some residents also in this forum, that some of the drugs which have failed and some of the drugs which are in pipeline. So let me start with, the saroglitazar first. So saroglitazar is, as I said, is a dual PPAR alpha and a gamma agonist. Now, these PPARs are the nuclear receptors, right? And they are involved in the lipid and carbohydrate metabolism. They improve the insulin sensitivity, improve your glucose control, and they also tend to have some anti-inflammatory and anti-fibrotic actions by acting on various, genes and proteins. So the data I'm going to show you about this molecule, there is a lot of real life data which is available on this molecule, at least from our country. But this phase 2 data, which is known as the Evidences 4, was presented in 2019 ASLD meeting. And in this was a phase 2 study. And in this particular study, multi-center study, number of patients were not large because this was a phase 2 study. 106 patients were involved, and they were divided into 4 groups, almost around 25 patients each. So placebo, saroglitazar 1 milligram, 2 milligram, and 4 milligram. And they wanted to look at the improvement in ALT and the reduction in liver fat as assessed by the MRPDFF. So what they found finally was that in the dosage of 4 milligram, saroglitazar in comparison to the placebo was efficacious for reducing the ALT levels, number one, and also causing the absolute change in the liver fat as assessed by the MRPDFF. They also looked at that how many patients had more than 50% ALT reduction, and that was also higher in the 4 milligram saroglitazar group. In addition to these primary endpoints of ALT reduction and liver fat reduction, the authors also found that there was improvement in insulin resistance and dyslipidemia in patients with NAFLD and NASH. So this was a phase 2 study, as I said, which was presented last year, and this is known as the Evidences 4 study. Then we had done a multi-center study in India, and this study was presented this year in APASL 2020. And this was again a multi-center study, and this was a biopsy-based study. And what we had done in this study is known as the Evidences 2 study. And in this study, there were 102 patients, which were biopsy-proven NASH with F1 to F3 fibrosis across 10 centers in India, and a NAFLD activity score of at least 4 or more, and score of each component of steatosis, lobular inflammation, and hepatocyte ballooning from each component. And they were then randomized into 2:1 ratio into saroglitazar 4 milligram and placebo. So what we found, the results were that at week 52, which is at 1 year, there were a larger number of patients, which was 52% in comparison to 23% in the placebo group, having reduction in the NAFLD activity score of 2 or more. And this was spread across more than 2 NAS components again. So I think again, thereby suggesting that saroglitazar is an effective drug in reducing the inflammation. And there were some secondary points, and this was without worsening of fibrosis. So there was improvement in NAS score without worsening of fibrosis. And there were some secondary endpoints like improvement in ALT levels, improvement in various cytokines and various other biomarkers, where also it was found to be effective. And if you look at the safety of this molecule, again, I think if you look at the adverse events, they were not major and they were not higher in the saroglitazar group, and they were all minor side effects, and predominantly they were the GI side effects which were minor. So in other words, saying that the drug was well tolerated by most of the patients. So because based on this data now, the saroglitazar in March this year has been approved by the DCGI for usage in patients with NASH with F1 to F3 fibrosis in India at least. So let me go on to the next class of drugs, which I said, which are available, have been tested in NASH, but not approved for NASH. And as I said, I will maybe give you a little overview about some of the anti-diabetic drugs, vitamin D, probiotics, and then we will come down to the hot topic of obeticholic acid. Okay, so I will not give you any data on metformin because most of the data which is available with metformin is a very good drug, but then unfortunately this has been not shown to improve liver histology in patients with NASH. That is why it is not recommended by any societies and has been not approved by the regulatory authorities. But this one study which I have picked up is basically a last year study, which was a retrospective analysis by Professor Nagachalasani's group from Indiana University, where they had around 200 diabetic patients and those who had biopsy-proven NASH with either cirrhosis or high fibrosis or bridging fibrosis. And they divided these patients into those who were taking metformin versus who were not taking metformin. And look at this, what they found was that the metformin usage was associated with lower risk of overall mortality or transplant, and also HCC in patients with metformin. So it is a good drug, but then as I said, since we do not have data on the histological improvement with this drug, it has not been approved for usage in patients with NASH. The other class of anti-diabetic drug is a GLP-1 agonist, which is a liraglutide. And this is an injectable drug which is given every day to patients with diabetes. And this is again a phase 2 study, small study known as a lean study, where they basically compared around 23 patients in each arm placebo, and liraglutide and looked at the patients with resolution of NASH. And they found it to be much higher, 40% in liraglutide group versus only 9% in the placebo group. Looks promising, and there was no improvement in the fibrosis. Looks promising, but then, as I said, the company has decided not to go for a phase 3 study. In addition, they are actually now exploring a molecule which is a semaglutide, which is also GLP-1 agonist, and there's some data or trials going on where the liraglutide is being compared with the weight loss surgeries or the bariatric surgery. So again, as I said, since we do not have a larger data, this drug has not been approved. There's some data, at least from our country and some of the other countries, on other anti-diabetic drugs, which are known as the SGLT2 inhibitors. And these are the drugs, something called the empagliflozin, or you have a dapagliflozin, or you have a canagliflozin, and the remogliflozin. And this is one study, again, I picked up from our country, which was MRI based. And there they showed that based on the MR-PDFF, the SGLT2 inhibitor empagliflozin was found to be improving the MR-PDFF. And also they showed that it also improves the serum ALT level, since the other markers of nectar inflammation and fibrosis were not seen. And there's one small study which has actually looked into that. Since we do not have a larger data, again, this drug would need more exploration and has not been approved. Vitamin D has been associated with fatty liver disease in multiple ways. There's even a meta-analysis available which has shown that patients with fatty liver disease have lower vitamin D levels. Vitamin D has also been associated with insulin resistance. But again, there is no good histological data to say that vitamin D improves liver histology in patients with NASH. We did a small work and we showed that the cytokine improvement and the ALT improvement does happen. But then, as I said, the histological backing is lacking with vitamin D. Finally, I think the use of probiotics, again, we know that the gut microbiota could be playing a major role in the pathogenesis of fatty liver disease in general and NASH in particular. And there's some data which has come up on the use of, probiotics, or what I would say the gut microbiota manipulation, which is by the probiotics or antibiotics. And to that extent, even FMT is being explored, the fecal microbiota transplantation. So this is again one study as a proof of concept study we did as a 2-center study in 40 patients, biopsy-proven NASH, and we showed that multi-strain, high-potency probiotic does improve liver histology. But then, as I said, the larger data is not available, so not approved. Now I'm coming to, as I said, the hot topic or the hot drug, which is actually being talked all over the globe now in fatty liver disease, which is known as obeticholic acid. So obeticholic acid is what? It is basically an FXR agonist. So what are these FXRs? FXR receptors are again nuclear receptors, which are predominantly involved in the bile acid metabolism. When the FXR receptors, they have some natural ligands. For example, chenodeoxycholic acid, which is a bile acid, is a natural ligand for FXRs. You have various synthetic ligands, and obeticholic acid is one of the synthetic ligands for the FXR receptors. And the stimulation of FXR receptors have been shown to improve the bile acid homeostasis. That is, they decrease the synthesis of bile acids, they increase the secretion of bile acids, but in addition, they also have been shown to have effect on glucose and lipid metabolism, also have anti-inflammatory and anti-cholestatic and anti-fibrotic and hepatoprotective properties. And that is the reason that OCA or obeticholic acid has been, explored in patients with fatty liver disease. So this is one study which was published 5 years back, known as the Flint study. The molecule is from the company called Intercept, and they had 2 arms, OCA of 25 milligram and placebo, and the drug was given for 72 weeks. And the primary endpoint was no worsening of fibrosis with decrease in histological activity of by NAS of 2 or more points, and they were all biopsy-proven patients, total of around 280 patients. So when they did the interim analysis, what they found was that in the group which received obeticholic acid, there was a significant fibrosis improvement in comparison to the placebo, though the NAS resolution was not very significant. But when they looked at the side effect profile, the OCA worsened the LDL levels, decreased the HDL levels, right? So, and the other side effect was pruritus, which was actually seen in around a quarter of patients with OCA in comparison to only 6% in placebo. But based on these positive results, the company went on to a phase 3 study, which is known as a Regenerate trial and which is still on. And the interim data of this Regenerate trial was presented last year in 2019 in the EASL meeting and then in the ASLD meeting. So this is the EASL data which was presented last year by Dr. Zubair Yunusi, and the interim analysis was done after 18 months of receiving obeticholic acid, and the data was available in around 930 patients. So they had 3 arms. One was the placebo arm, OCA arm, which was 10 milligram, and obeticholic acid, which was 25 milligram. And as I said, they did analysis at 18 months, and mind it, they included in this analysis of patients with NASH, those who had only F2 and F3 fibrosis, right? So the results were, and this was published again last year in December in Lancet, Professor Yunusi being the first author. And when they presented this data in EASL and published this, what this shows us that whether you do the intention to treat analysis or per protocol analysis, the 25 milligram of obeticholic acid was superior in decreasing or improvement in fibrosis, in causing improvement in fibrosis in 23% of patients in comparison to 12% in the placebo arm. And in the per protocol, it was 28% and 13%. They did not find any difference as far as the NASH resolution was concerned. The improvement was only in the fibrosis. Further, when they looked at how many patients actually had worsening and improvement in fibrosis, larger percentage of patients in the 25 milligram of OCA had improvement in hepatic fibrosis in comparison to 10 milligram OCA and the placebo. Further, when they looked at the biomarkers, the ALT, AST, gamma GT, they all decreased. The ALP slightly went up. But then coming to the side effect profile, again, if you look at, pruritus was seen in around 50% of these people. But the grade 3 pruritus was not very large, but overall pruritus was 1. And as I said, it does this had effect on the lipids, which means the LDL went up and the HDL came down. As I said, they did a secondary analysis of this interim group and presented it in the ASLD, where this was presented by Professor Arun Sanyal. And what they did in this particular analysis was that they added few more patients. So the patient number here became 1,218. So what they did was they added patients with F1 fibrosis also, in contrast to the EASL data where they had only F2, F3 fibrosis. But here the F1 fibrosis patients had some risk factor of having a severe liver disease, whether they were old, they were diabetic, hypertensive, dyslipidemic. So some risk factor with, F1 fibrosis. And then the safety profile, they looked at even in a larger number, which was around 900 patients. So the data again shows that the fibrosis improvement by 1 or more stage was seen more commonly in the OCA group, 21% versus 10%, so almost double. And if you look at the NASH resolution in this larger number, was again seen better in the OCA 25 milligram group, 15% versus 8%. So again, I think almost double. So this drug then showed that this is efficacious, both in improving the NASH as well as the hepatic fibrosis. As I said, pruritus was a major issue. So Dr. Zubair Yunusi also presented a paper in the same meeting where they looked at the health-related quality of life, which is getting affected with pruritus. And what they showed was that because of pruritus, initially there was a reduction in health-related quality of life for maybe 6 months or so, but then slowly it improved and reached the baseline over 18 months. So then they said that pruritus probably was not a major issue here. There's another trial which has just been completed. The enrollment has just been completed. And this was the trial which was known as a reverse study, where the OCA was actually assessed in patients with compensated cirrhosis, which means F4 fibrosis. So the results are still not out. And I think we will have to wait and watch to see whether the OCA is effective in patients with F4 fibrosis also. Finally, coming to my last 2 or 3 slides on, as I said, for the residents' sake, I need to just say that they should know some of the name of the drugs which have failed, at least phase 3 data have failed in showing the improvement in NASH. And one such drug is called the elafibranor. So elafibranor is basically, again, a dual PPAR agonist. And this is in contrast to saroglitazar, which is alpha gamma agonist. This is alpha delta agonist. And the phase 2 data of elafibranor, which was presented few years back, which was known as Golden 505 trial, was found to be effective in causing improvement in patients with NASH. And that is why the company went ahead with a phase 3 data. And they had 2 arms of elafibranor, 120 milligram and placebo. But when they did this interim analysis, and there's a news which is out very recently, what they have found is that this drug has not been found to be better than placebo in improving either the NASH or in the fibrosis. The second debacle which happened this year for a very important drug was a molecule from Gilead, and this molecule was called the selonsertib. And selonsertib is basically an ASK1 inhibitor. So what is ASK1? ASK1 is an apoptosis signal kinase 1. So, apoptosis plays a major role in the pathogenesis of patients with NASH. So the company had, again, a phase 2 data, which was presented again 2-3 years back in ASLD and were found to be effective in improving fibrosis in patients with NASH. So they went ahead with 2 phase 3 studies, and they were known as Stellar 3 and Stellar 4 studies. So in Stellar 4, they were recruiting patients with F4 fibrosis, whereas Stellar 3 was for F1 to F3. So again, what they found, I think the interim data when they presented last year, that this drug was not working better than placebo. So the trial was prematurely, interrupted. Last 2 slides, as I said, again, the residents need to know what are the drugs in pipeline, and we will have to wait and watch to see whether they can be effective or safe in patients with fatty liver disease. And the one drug is so-called the sinecrivirok. So sinecrivirok is a drug which is, again, a chemokine inhibitor, and specifically it is a CCC2 and 5 chemokine inhibitor. And this is a molecule from a company called Allergan. And the phase 2 data was again published 2 years back and was called as a SEN2 trial, and which was found to be effective in improving fibrosis in comparison to placebo. So the company is now enrolling patients in a phase 3 study called the Aurora study, which is recruiting large number of patients with NASH with liver fibrosis. And they are looking at the safety and efficacy of this molecule, but the results are awaited. The other molecule, which again the phase 2 data was found to be effective and which was published again last year, was a molecule called the resmetirom. And this is, the thyroid hormone receptor beta agonist, which specifically have actions on the liver. And this was found to improve hepatic fat. And the company is now actually going a phase 3 study, which is known as a MASTRO-NASH study. So this is again exploring the utility of this particular drug in patients with NASH. So, ladies and gentlemen, I would like to summarize now by saying that when we talk about the pharmacotherapy of patients with NASH, as I said in the beginning, it is very important to differentiate within fatty liver disease in the beginning by your non-invasive assessment, and if need be a liver biopsy, whether your patient has NASH or it is NAFL. Because pharmacotherapy, as I said, would be directed predominantly towards patients, those who have NASH with or without fibrosis rather than towards NAFL, number one. The second thing which I said in the beginning was that irrespective whether it is NAFL or NASH, with or without fibrosis, whether you are using pharmacotherapy or not, we should not forget that this is a lifestyle disease and we have to take care of all the risk factors, and the lifestyle interventions are the key in the management of non-alcoholic fatty liver disease. So if somebody is obese, he has to lose weight, diabetes, hypertension, dyslipidemia, everything needs to be controlled. So coming to the drugs, I spoke about a drug which is approved in India, which is a saroglitazar, dual PPAR alpha and a gamma agonist, and has been found to be effective. And as I said, it's been approved in India for patients with NASH with F1 and F1 to F3 fibrosis. I showed you some data on some of the other drugs which are available, have been tested in NASH, but not approved. So these are mainly the anti-diabetic drugs, metformin, liraglutide, SGLT2 inhibitors, vitamin D, and probiotics. But the major drug which I showed you, which has shown promising results very recently, is the obeticholic acid, which I told you is an FXR agonist. And the phase 3 data interim analysis actually has shown us that this drug is very effective in improving fibrosis as well as NASH, but not yet approved for the treatment of NASH. Finally, I showed you some data on the drugs which have failed, which is the elafibranor, PPAR alpha and a delta agonist, and selonsertib, which is an ASK1 inhibitor. And finally, two drugs which are in phase 3. One is the sinecriviroc, which is a chemokine inhibitor, and other is the resmetirom, which is, the thyroid hormone receptor beta agonist. With this, I like to conclude, and thank you very much for your kind attention. Dr. Mamoon, you are not audible. You need to unmute yourself. Dr. Mamoon, you are not audible.
Yes. Audible? Yeah. So thank you, Ajay. We have a good number of questions for you. And as expected, most of them are on obeticholic acid. So if I start asking the questions, I'll first concentrate on the obeticholic acid questions. So Dr. Abu Saleh Sadekul Islam from head of the Department of Hepatology, Bogra Medical College. He wants to know the criteria of stopping obeticholic acid. When will you stop obeticholic acid? Is there any such criteria?
So what I would like to respond is we still do not have this drug or a molecule still approved for patients with NASH. We have to be very, very clear, right? So the criteria of stopping would obviously come in when we start using this drug, but then in this particular study, the phase 3 study, which is going on still, they have done this analysis, which is at 15 months, right? And they tend to go further, maybe by up to, I think, October 2022. So which will be total of, I think, around 5-7 years of this thing. So if you ask me in clinical practice, as and when it is approved, how will we monitor and how will we take a call on stopping the drug? My perception would be that we will have to look at both the non-invasive assessment and, if need be, sometimes an invasive assessment. And non-invasive assessment would be based predominantly by the serum, the liver enzymes, which is the ALT levels, whether the ALT is improving or not. That has been shown by this drug to improve the AST, ALT number one. Then this can be taken as a marker of inflammation, though, as I said, sometimes you can have an argument by saying that ALT may not be elevated in patients with NASH, and you can have NASH even with normal ALT. But this is what the drug has shown, that the ALT does improve. So you can use this as one of the non-invasive marker number one. You can also use a non-invasive assessment with FibroScan. We do not have a data on this, but yes, if the FibroScan values are improving, this can give you an indirect evidence that there could be some improvement which is happening either in fibrosis or even in inflammation, because sometimes the NSM does get affected even by inflammatory markers. Finally, I think if you want to be doubly sure, I think, as I said, the data has to be then biopsy based, which may or may not be possible in the clinical trials. You can also do various other biomarkers of inflammation and fibrosis.
So, two more questions which are quite related. One is by Dr. Alok Kumar Raha, Head of Hepatology at Chittagong Medical College, and Dr. Tahir from Dhaka. So Alok wants to know whether we can start obeticholic acid based on ultrasound evidence of fatty liver only, or a fibroscan is needed. And Dr. Tahir adds whether obeticholic acid can be used in our daily clinical practice in management of NASH.
I think I have to again reiterate that the obeticholic acid has still not approved for the treatment of NASH even by the FDA. The application is still pending. The meeting was supposed to happen in June, and which has again been postponed. The advisory committee has asked for some more information and more data from Intercept, and that probably may have been provided. So it is still not approved. Now, again, coming to the hypothetical question, as and when it is approved, so how will you start? Ideally, this has to be given only in patients with, as I said, NASH. So NASH diagnosis, it is very difficult to make without a liver biopsy. But yes, you can predict NASH based on various non-invasive assessment, and one of them can be fibroscan. If the fibroscan shows you an LSM value of 8 and more, which we have taken in most of our studies as a marker of significant fibrosis, you can take a decision in your clinical practice of starting this drug as and when approved.
And Dr. Sohail Rana wants to know whether there is any role of obeticholic acid in liver cirrhosis.
Again, as I said, the phase 3 study of 900 patients on obeticholic acid in compensated cirrhosis, which is known as a reverse trial, has just been completed. So we are waiting for the data to be out and the results to be out. Only then we would know that whether it really works in F4 fibrosis. Till now, what we have data is only from F1 to F3 fibrosis. So F4 data is still awaited.
And Dr. Abdullah Mahmood from Chittagong Medical College wants to know how will you manage the pruritus that obeticholic acid induces? Stopping the drug?
I think that is a very important question, and most of the experience of using pruritus in patients using obeticholic acid is available, because this drug we know has been approved for PBC. So PBC patients in general have pruritus, and this tends to worsen pruritus, and even with patients with NASH. So there are 2-3 ways people have done to basically take care of pruritus. Number one is what they call is the dosage titration. So if somebody, for example, is taking a higher dosage and NASH say 25 milligram or PBC 10 milligram, you can titrate the dose to a lower level, number one. You can make it maybe not every day to make it thrice weekly or twice weekly, reduce the dosage as such. And some people even talk about something known as a drug holiday, that you can give a break for a few days and then you restart. That is one. And if you talk about the various pharmaceutical drug agents which have been used to control pruritus, there is data to say that you can use antihistaminics, which people have done to control. And second is you can use the drugs like cholestyramine, which are the bile acid binding agents, to control the pruritus in these patients, in addition to the extra measures of, avoiding the hot shower baths and keeping your hands and all moist, and all those things have been suggested. This is basically managing pruritus of any cholestasis.
Yeah. And Dr. Roxana Begum wants to know whether orlistat can be used to reduce manage obesity in a patient with fatty liver disease.
Sorry, I didn't get the question right.
Can we use weight-lowering agents like orlistat for patients with fatty liver disease? Yeah.
With NASH. Okay, there is some data too. I didn't talk about those drugs, the weight-lowering drugs, including the orlistat and the other drugs. There was some data to say that they do work in reducing body weight in patients with fatty liver disease. But then, as I said, what you need in fatty liver disease these days is a large data in the form of what we call the phase 3 data. And you also need to show with drugs what we are looking for are the histological improvement, both in the necroinflammation and fibrosis. That kind of data is not available with any weight-lowering drugs.
So there's a question regarding vitamin E. Dr. Alok Kumar wants to know whether vitamin E can be used in both diabetics and non-diabetics. And there's also a question from Dr. Tahmid who wants to know how long can you use vitamin E in these patients?
Vitamin D or E?
E, vitamin E in patients with diabetes and in non-diabetics, and if so, how long?
Okay, so vitamin E, if you look at the original PIVNS trial, which was given for 96 weeks, which is almost 2 years, in that particular study, they had taken patients only those who were non-diabetics and those who had biopsy-proven NASH. So traditionally, when the ASLD recommended the vitamin E in patients with NASH, they said it has to be used only in patients with biopsy-proven NASH and in patients those who do not have diabetes. And they said that at that particular study, they had excluded cirrhotics. So again, as I said, they said no cirrhosis, only F1 to F3 fibrosis, and no diabetes and biopsy-proven NASH. But thereafter, we have had data in patients with cirrhotics, and we have had data in patients with diabetes also. And I showed you one retrospective analysis from Naga Chalasani's group, where they had patients, those who are again diabetics and non-diabetics, and they all had high fibrosis or cirrhosis. And this was not a histology-based study, but they did show that the transplant gets delayed and there was some improvement in the mortality which happens. So I think you can use it in diabetics and non-diabetics both, and you can use it in even in patients with high fibrosis.
And Dr. Faiz Khondakar from Shoisaradi Medical College, Dhaka, he wants to know, is there any study showing that saroglitazone is superior to vitamin E and pioglitazone in NASH?
Okay, there is no head-to-head comparative trial of saroglitazar with vitamin E or pioglitazone. But if you look at the separate studies and if you look at the data on, say again coming to the PIVNS trial, and if you look at the improvement in necroinflammation, which happens with vitamin E, is seen in around 30-40%, whereas the saroglitazar in the study which was done in India showed improvement in necroinflammation in around 52%. So we do not have a head-to-head comparison, but looking at the separate figures, it looks like that Saro may be more effective.
So there is a question about combination therapy. Can we use obitacolic acid plus pioglitazone or obitacolic acid plus vitamin E, such combinations in managing NASH?
I think to tell you, yes, NASH is actually a difficult nut to crack, and the individual drugs are really not working very well, I would say, because the pathogenesis of fatty liver disease, we know, involves so-called multi-hit, factors, or multiple factors are simultaneously involved. So yes, there is the concept of using a combination of drugs, and people have tried it earlier. And there was a recent study which was published last year with various combination of drugs, but unfortunately did not succeed. We are planning to have a study of the Indian Consortium of Non-Alcoholic Fatty Liver Disease, the ICON-D group, where we are planning to combine the Saro with obitacolic acid. So there are thoughts going on with the combination treatment, but till now we do not have a very convincing data to say that the combination works better than the monotherapy.
We have Professor Khaja Nazimuddin, a very eminent and senior endocrinologist of the country. He wants to know, can we use metformin in advanced fibrosis compensated cirrhosis due to NASH, as insulin resistance is a factor and metformin reduces the resistance. So role of metformin in NASH, and he's also saying that since ursodeoxycholic acid has no role, can we recommend not to use UDCA in NASH?
Yes, I think first coming to the UDCA or UDCA, yes, I think the randomized control trial, placebo-controlled trial have shown that the UDCA is no better than placebo. So I think if you want to use it, UDCA in patients with fatty liver disease, this is only for the placebo effect. And to tell you the truth, we do use it in our clinical practice just for the sake of a placebo effect, but it doesn't really improve the histology. Now, coming to the metformin, as I said in my talk, It's a very good drug, very safe drug, doesn't have any side effects, and has various other, beneficial effects, both in non-cirrhotics and in cirrhotics. But unfortunately, the non-cirrhotic data in NASH did not show any histological improvement. That is why it is not recommended. The cirrhotic data, which I showed you, was again from Dr. Nagachara Sani's group, where it is a retrospective analysis. And there they have shown that if you use metformin, it does help in decreasing the incidence of HCC and overall improving the outcome. So if there is a diabetic patient who has NASH and who has cirrhosis, I think you can use metformin if you wish to.
There are a good number of questions on vitamin D, pioglitazone. I think you have answered those questions, and for those who have been asking these questions, this program is live on Raj TV and from the website, the Facebook page of Beacon Pharmaceuticals. If you record it there, you can go through the lecture and get your answers. Now, one question from Dr. Fazal Karim. He's a very senior hepatologist. He wants to know the preference of edible oil. If he wants to use oil for cooking, which one would you recommend? Rice bran, sunflower, or something else?
I know my topic was not to cover on the lifestyle interventions and on the other things. I think that is a topic by itself. But yes, I think this is a very valid question. And as I said, lifestyle interventions play a major role. And within the lifestyle intervention, other than the exercise and the control of risk factors, diet also plays a major role. We know that. And if you talk about the different kind of oils, we do not really have, again, a comparative data. But then there is good data to suggest that if you have to use a particular diet and oil in patients with fatty liver disease, it has to be a Mediterranean diet. And if it is a Mediterranean diet, and if you look at the oil which is used in Mediterranean diet, is basically olive oil. So I think it's an indirect answer. But yes, we do not have any head-to-head comparison between different oils. But if you want to choose, yes, olive oil would be, my answer would be an olive oil.
Dr. Irshaduddin Ahmed, he is a senior gastroenterologist from Chittagong. He wants to know, is there any role of endoscopic intervention for morbid obesity in NASH patients? The balloons and things that
absolutely. Again, I think since I covered only the pharmacotherapy, but endoscopic interventions are, again, I would say, being explored for the treatment of obesity in patients, in obesity in general, and fatty liver disease in particular. And to tell you the data, there is some small data which is available with gastric balloon in patients with NASH and obesity, and it has been shown to be effective in causing weight reduction. But again, there is no randomized control trial and no study which has looked at the histological improvement. The other good data which was presented last year, 2019 ASLD, was on the DMR, which is a duodenal mucosal resurfacing, which is also an endoscopic technique, where you kind of ablate or resurface the duodenal mucosa. And that particular study, which was presented in ASLD, as I said, did show in patients with fatty liver disease and diabetes that there is improvement in hepatic fat and the ALT levels. So as I said, I think the endoscopic interventions are being explored and may have some future.
Last question for you. Obviously, not the last question. There are hundreds of more questions. I'm sure if you allow us, we'll be inviting you many more times. We are very popular in Bangladesh. So for the sake
Thank
of
you
time,
so much.
it is close to Jummah prayer, so we'll conclude. So maybe the role of hydroxychloroquine and or colchicine in reducing cytokine level. Is there any evidence? This is a question by Tariqul Islam from Bogura.
Hydroxychloroquine is in the news these days because of more of COVID-19, and rheumatologists have been using this drug for very, very long time in various rheumatological disorders. But I'm not aware of any data of usage of hydroxychloroquine in patients with NASH. Colchicine is a journal anti-fibrotic agent, and I remember when I joined hepatology way back 30 years back, and we did not have any major drugs for hepatitis C and hepatitis B. And that time, I think we used to use colchicine as an anti-fibrotic agent, but I'm not sure whether it really worked, because we never did any, there was no fibroscan available that time, and we never did any histological studies on that. And these days, I don't think people use colchicine as an antifibrotic agent.
Thank you. And those who want to listen to Dr. Ajay Duseja again, the Indian National Association for the Study of the Liver will be organizing a webinar at 7 p.m. our time, 6:30 p.m. Indian time today, where Dr. Ajay Duseja and Professor Anil Arora will be speaking. So there is again
opportunity. And Professor Zubair Yunusi is also there.
Yeah, so 3 of them will be speaking, and there is opportunity for us to listen to him again. Now, thank you, Ajay. We'll get back to the expert panel. First, I invite Dr. Sheikh Mohammed Fazle Akbar. Dr. Akbar, if you please give your comments about today's deliberations.
Can you unmute yourself, Professor Akbar? You need to unmute yourself. You need to unmute.
Can you?
Yeah,
can you hear?
Yeah, we can hear.
Okay. The thing is, this just very simply because the time is going on. First of all, from the slides and everything, I must thank you because it's a very good compilation. And the most important thing, we don't know the pathogenesis of the NASH. So we're using a lot of drugs, some diabetic, some for other purposes. And actually the effects are bile acid, lipid altering agent, and incretin-based therapies, agent terminating inflammation, gut and microbiome, and antifibrotic drug. So, and also possibly everyone has marked that about 8% to 12% people is improving in placebo group. So we are lacking. Number one, we are not sure why the placebo group is improving in such a manner. And second thing, we are, and everybody is looking for evidence-based therapy for NASH because we are using different types of therapy, which are also indicated for many other conditions. And the NASH, the process of the pathogenesis is possibly something, it doesn't come from the NAFL or MAFL only. It, for genetic and other factors, the things happen. So maybe we'll have to discuss and we have to go on with different drug for a long time. So this is just simple because the most important thing too, the placebo is improving. And the second is that we don't have any evidence-based therapy. So we have to look for the evidence-based therapy because all these drugs have been used for some other purposes. So there must be some new type of things which will come possibly in the future. Thank you.
Thank you very much. Points are well taken. Yeah.
Yes. And actually, I just didn't mention another thing. Actually, Dr. Mamun Al-Mahtab used one drug in a phase 1 trial, antifibrotic direct drug. We obtained it from Cuba. And that's also, we have the safety and other result, so antifibrosis. So the NASH has a lot of problem. So these are the other things. And today time is not so much that we can discuss all this issue, but maybe in the future we can discuss all this issue.
Yeah.
Thank you.
Thank you, Dr. Akbar. Now we go to Professor Chittaranjan Devnath, Principal, Mahansi Medical College, for his brief comments, please.
Very brilliant lecture. I would like to thank Professor Ajay, and I will invite Professor Ajay to Bangladesh after our Corona situation is over.
After the COVID pandemic is over, yeah, sure.
Yes, thank you.
Thank you very much.
Actually, Ajay was expected to visit Bangladesh. We had given him a very invitation long back to be here today. Unfortunately, we could not have him today. So thank you, Professor Chittaranjan Devnath. We go to Professor KMJ Zaki now, Dean, Faculty of Medicine, State Medical University, for his comments.
He needs to unmute himself.
Thank you very much. Can you hear me?
Yes.
Yeah, we can hear you.
Thank you very much, Dr. Ajay. You have a nice presentation. But in Bangladesh, cerebrolidazole is not available. So we have got only obeticholic acid. And in Bangladesh, our data suggests that 45 to 55% of our patient has got NASH. It's unbiased data because this data has come from our BSMMU student.
Right.
Can we use obeticholic acid blindly in our patient?
As
Because
I
we have
said,
got
you
no
have
source of surrogate.
See, I'm pretty sure you also have a regulatory agency in your country who would be regulating the use of drugs. So as I said, the drug is still not approved by the US FDA, where the application is still pending. After the FDA, if and when it approves, then other countries can take a call and ask for the waivers for its usage in patients with NASH, like we have done for various other drugs, like for hepatitis C drugs. But as I said, right now we are still waiting. Right now, if you want to use it, this will be a totally an off-label use, right? Because it has still not been recommended. So I would suggest that you should wait and watch till it gets a regulatory authority, and your regulatory authority gives you an approval to use it in patients with NASH. Because some of these things sometimes can even have medical legal issues also. But this is still not approved.
Thank you. Thank you. Thank you very much.
Thank you. So before I conclude, I have two declarations to make. We are grateful to Beacon Pharmaceuticals Limited. They were the scientific partners for this meeting. And we are grateful to Raj TV. That's an online television channel, medical-based channel of Bangladesh. They have broadcasted the program live, and through them we'll be reaching thousands more audience. I invite all the participants to watch TBC TV at 6 p.m. this evening. There's a special talk show on Bangabandhu's 3rd International NASH Day, where Dr. Fazla Akbar from Japan and Dr. Pradeep Bhaumik from India will come to us. And at 10 p.m. our time, we have another webinar where Dr. John Lewis from University of Miami will be linked. That will be from 10 to 11:30 p.m. Very sorry for the odd timing. That is for the US time difference with Bangladesh, and he'll be speaking also on NASH. So with that, I thank once again Dr. Professor Ajay D'Souza. I thank our panelists, Dr. Sheikh Mohammed
Thank you very much.
And all the participants for being with us. Thank you very much. We'll get back to you very soon. Thank you.
Thank you very much. Thank you. Thanks for the invitation.
Thank you. Thanks.
Believe that by adding Bangabandhu's name to this day, Bangabandhu is glorified. Rather, the impact that Bangabandhu has in our region, we believe that by endorsing the day and by adding Bangabandhu's name to the day, it will create more appeal to the people and will raise awareness.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our